So I was asked to speak on familial risk. What have we learned so far? First of all, I do have some relevant disclosures. I do paid consultancy work with Myriad Genetics and Abcodia. So the specific questions I was asked to address were, what is a significant family history? How can you get your risk assessed properly? What should you do if your risk is increased? And are there any alternatives to risk-reducing surgery? And by risk-reducing surgery, we're speaking specifically about ovarian risk-reducing surgery, which means removal of the ovaries and the fallopian tubes. So why is a family history important? Well, it really is absolutely crucial. I've been involved in this area now for 19 years. I think next year will be my 20th year in being involved in familial ovarian cancer. And it's not just a fascinating subject, it's an immensely important subject because of all of the benefits here outlined on the screen. By identifying a family as being at increased risk, you may, if you're lucky, be able to do some genetic testing to really clarify that level of risk. But even if you're unable to do genetic testing, with careful assessment, primarily by clinical genetics consultants and nurse counsellors, you can really define with a reasonable degree of accuracy an individual woman or man's risk of getting a specific cancer. And then you've got the opportunity to offer them interventions which are now known to be successful in preventing cancer in those in the family who are as yet unaffected. And also more recently, many of you will, I'm sure, have heard that very clever doctors are designing targeted therapies designed specifically for people with specific mutations in their ovarian and other kinds of cancer. So it also offers up other opportunities for specific successful treatments for those who've already got cancer, but I think, to my mind, even more importantly, it allows you to prevent the cancers in the first place in a wider number of people by going out to any blood relatives of those affected by cancer and trying to define their individual level of risk. So first of all, what is a significant family history? Well, let's first of all talk about the type of cancers that are important here. Obviously, ovarian is very important. That's why we're here today. And it certainly is a cancer that's known to be associated with an increased chance of finding a predisposition in the family that means other members of the family may be at risk. In particular, high-grade serous ovarian cancer, which is probably many of you are aware is the commonest kind of ovarian cancer, not just in the general public, but also in those with genetic mutations that increase the risk of ovarian cancer. There are also other kinds of ovarian cancer which are less common, but are associated with an increased risk of there being a predisposition in the family, and those are endometrioid and to a certain extent clear cell cancers. Breast cancer is also crucially important in the family, particularly if it's women under the age of 50, if it's what's called a triple negative cancer, which means it's not a hormone sensitive cancer, it doesn't express any of the receptors that allow you to treat those women with anti-hormone medication. If it's bilateral, meaning the woman has had the cancer on both sides, in the left and the right breast, not a metastasis from one to the other, but two separate cancers. And also male breast cancer, it does happen, believe it or not, and if it does happen, there's an increased chance of there being a predisposition in the family that's caused it. Endometrial or womb lining cancer is also something that can indicate an increased risk of inheritance in the family. Colorectal cancer, especially below the age of 50, and to a certain extent, pancreatic and prostate cancer when in combination with breast and ovarian. But that weak is substantially weaker than the other links I've outlined above. It's important to know, because some of you may have these diagnoses or be related to those with these diagnoses, that mucinous invasive ovarian cancer and what are called borderline ovarian tumours are not indicative of an increased risk of a genetic predisposition in the family. Now, with all inherited risk of cancer, an early age of onset of the cancers in the family is a little hint that there may be an inherited risk going on. And there are certain ethnicities where there is an increased likelihood of a genetic mutation being found in the family. And in the UK, one of the main ethnicities for that is people who are of Ashkenazi or Eastern European Jewish origin. And the reason for that is there are what are called founder mutations, meaning that in that society, in that ethnic group, people tend not to marry out so much. So when they have children, it's more likely that genes that came with their ancestors millennia ago have still remained within that population. And there are some studies suggesting that amongst Ashkenazi Jews, there could be a risk as high as 1 in 40 of carrying a BRCA1 or BRCA2 gene mutation. So which specific combinations are important? Well, ovarian-only families, breast-only families families where there's a combination of ovarian and breast, and to a certain extent prostate and pancreatic as well, and those would be indicative of possibly a mutation in BRCA1 or BRCA2. But some of you may be less familiar with something called Lynch syndrome, which tends to cause not just ovarian, but actually more often endometrial or womb lining cancer and colorectal cancer, particularly in people under the age of 50. But it's also important to know that these are not cast in stone. These are not 100% reliable ways of identifying those at increased risk. And family history is often inaccurate through nobody's fault. People think that their granny died of a specific kind of cancer, but when you actually get the death certificate through, it turns out they died of a completely different cancer. And it's also important to note that not all families with inherited mutation have a history of cancer. And that's been shown in many studies, but I just thought I'd highlight recently, because this is an excellent study which has been funded by Target Ovarian Cancer, which looked at women with ovarian cancer to see what proportion had a genetic alteration or mutation. And those women who had ovarian cancer and were found to have a mutation, 1 in 4 of them had no known family history. So you can see that it is possible for some families to carry a mutation without actually being aware of it, and that's an important point. So, given all that complexity, how do you get your risk assessed properly? Well, the first thing is you have a responsibility to yourself and your family to help the medical professionals who are going to guide you through this process. And that means you need to get as much information as possible. You need to know, in particular, what kind of cancer they had, and if possible, at what age they got it, because that can be important as well. I'm sorry, it doesn't actually specifically say the age on the slide there. But it's also important to know, if you're not aware, that you can get this information yourself relatively easily. If you go to your local town hall, speak to the registrar for births, deaths and marriages, and you can obtain the death certificates on any relatives, any grandparents, great-grandparents, people long gone. You think they had a certain kind of cancer, there's a rumour in the family, you can actually do something to clarify that. You should then go along to your GP and say, I'm concerned about this, look at my family history. And if you're lucky, you'll have a GP who knows a lot about this and understands it very well. If you're unlucky, you won't. But the great news is, in 2016, a friend of mine at Guy's and Thomas's Hospital, Andrew Kulkarni, who's a clinical genetics consultant, has developed an app, and the details are there. So far, it's only available on iPad and iPhone, but I urge you, if you're interested in this area, to download it. It's just search for cancer genetics on the iTunes store for apps, and you'll find this application. It's the top hit on that. It's a really, really superb application. I've used it myself in the clinic. I honestly don't think you need to be a medical professional to use it. You certainly need to get a medical professional to confirm what it's telling you, but it'll help guide you through whether or not you might have an increased risk in your family. And the bottom point is incredibly important, and sadly, there are many doctors who don't realise this. Just because the cancers that are inherited that we're talking about today predominantly affect women, it doesn't mean they can't be passed down by the man. They are equally inherited from either side of the family. So don't ignore a family history just because it's on your dad's side. It may be crucially important. So what can you do to reduce your risk if you are found to be at increased risk? Well, there are various lifestyle, reproductive choices you can make. The first thing is to know is that the contraceptive pill is well known to prevent ovarian cancer in the general population, and there's some evidence that it also does so in women at an increased genetic risk. But a slight word of caution there, you should probably avoid the pill if you're known to be a BRCA carrier if you're under 25, because it may make your already very high risk of breast cancer even higher. Breastfeeding is protective. There are a whole host of reasons why breastfeeding is great. We all know that. But another advantage is it does seem to reduce the risk of ovarian cancer. And pregnancies are also protective, especially the older you are, perhaps because the pregnancy in some way wipes the slate clean with mutations that have occurred so far. And that having a BRCA mutation, for example, in itself is not enough to get cancer. You need to get additional mutations beyond that before you develop a cancer. Obviously, you don't get pregnant just to reduce the risk of ovarian cancer, but it's nice to know if you've had children that they've actually reduced your risk a little bit. Sadly though, none of these are guaranteed to prevent ovarian cancer, so it always comes down to risk-reducing surgery. RRSO stands for risk-reducing salpingo-oophorectomy, meaning removal of the fallopian tubes and ovaries. So is it necessary if you are definitely at increased risk? Yes, because it may save your life. And we've got good evidence now from 2 large prospective studies showing that at least in the first 5 years or so of follow-up, which is all that's been reported so far, what's known as all-cause mortality, meaning death from any cause, is reduced in the women who are at increased risk due to BRCA mutations and had their tubes and ovaries removed. There's also a possible protective effect against breast cancer if you have your tubes and ovaries removed premenopausally, particularly before the age of 45. This is actually a little bit controversial now, so I don't think we should be 100% reliant on that. And we're waiting on some further data from the UK Embrace study to come out, hopefully later this year, which will clarify that issue for us. So when should you have the surgery if you're at high risk? Well, as with all things, it depends. It depends on which mutation you have. It depends on whether we know you have a mutation or not. Do you already have menopausal symptoms? For example, are you already past natural menopause, or are you taking tamoxifen as treatment for or prevention of breast cancer? What age did your relatives get their cancers? What age did they go through the menopause? These are all the complex issues that need to be discussed with a clued up gynecologist or gyne-oncologist before you submit to this kind of surgery. Should you have HRT if you have the surgery? Again, it depends. It depends on the age and presence of menopausal symptoms. Have you already had breast cancer? And if yes, you need to discuss this in advance of the surgery with your breast oncologist. There are certain examples where it may be permitted for you to have HRT, such as if you have a breast cancer that appears to be non-hormone sensitive, or if you just have such miserable menopausal symptoms that you really feel something needs to be done. And then you can have an in-depth discussion with your oncologist about whether they think it's reasonable for you to have HRT. So finally, are there any alternatives to such a drastic action as having your tubes and ovaries removed? Well, this is a really hot topic at the moment. Some of you may have heard about this. Can you get away with having just your tubes removed only? And the reason for this statement is there's a lot of evidence now suggesting that at least in the BRCA1 and BRCA2 carriers, those cancers start at the end of the fallopian tube rather than on the ovary. And there's limited evidence from clinical studies and also animal models which says that at least some of these ovarian cancers do actually start outside the fallopian tube, which we find concerning. Although evidence from the general population suggests that if you do remove the fallopian tubes, you can, for example, for an ectopic pregnancy or as part of a sterilization procedure, you can halve your risk of ovarian cancer. But the bottom point is absolutely crucial for you to understand. There's currently no evidence of the safety of this approach in BRCA carriers. It's not widely practiced as yet, and there are various studies going on around the world looking at whether this really is a safe alternative or not. Why? Well, first of all, most importantly, it may offer less protection than salpingo-oophorectomy, meaning removal of the ovaries at the same time as the tubes. It might result in premature menopause because even removing just the fallopian tubes does to a certain extent interfere with the blood supply to the ovaries, and that may potentially trigger early menopause, but we haven't got any long-term data on that. We've got short-term, 6-month data saying it doesn't cause a premature menopause, but that's not long enough follow-up. Will you return to have your ovaries removed once you've gone through the menopause? You may think, hey, I've had my tubes removed, I haven't got menopausal, I've gone through the menopause now, I don't have any more symptoms, I don't really fancy a second operation. That may not be safe. And a second operation, of course, reduces you to increases your risks because you've had to go through 2 operations rather than 1. And any operation, however simple, has potential risks. And the second operation might be technically more difficult because the first operation might have caused scar tissue or adhesions within your pelvis, which make it harder for the surgeon to go back in and remove your ovaries once you've had your tubes removed. What about screening? Well, you've got to remember, screening is not going to prevent ovarian cancer. Your best hope is it's going to pick it up early. And we haven't as yet got really clear evidence that it saves lives in the high-risk population. But in the general population, there's some very encouraging evidence which is awaiting 2 years further follow-up to confirm that it may save some lives in those women who are screened and are unfortunate enough to get ovarian cancer in the general population. Now, the study I've been involved with, the UK Fox study, will be reporting later this year. We're literally about to submit the paper. And this was done using 4 monthly CA125 blood tests, analysed using the same algorithm looking for rising levels of CA125 that was used in the UK CTOX general population screening trial. And we've already presented data, so this is not confidential, showing that screening detects most, in fact nearly all of the ovarian cancers before they cause symptoms. And it's associated with a very high rate of complete cytoreduction. And you'll be hearing more later today about how important it is if all of your tumour can be removed at the time of your first operation, which is what we mean by complete cytoreduction. So it does look like screening may enable this more in women who are screened compared to those who are not screened. But it does not detect microscopic cancers that you find unexpectedly in women with normal screening tests when they go through to have their risk-reducing surgery. And for this reason, screening should not be used as an excuse to put off your risk-reducing surgery indefinitely. So if you are at high risk, the safest option is to undergo the surgery once you're old enough, once you've completed your family, and once, in most cases, breast cancer accepting, you're prepared to take HRT. So my last slide, I just want to put in a quick plug here for the BRCA Protect Clinic at UCL. All the details are on that website there. We're looking for any women aged between 18 and 75 who've never had cancer, in particular BRCA carriers. I'm sorry we can't provide travel expenses, but we will give you a £25 M&S voucher. We're taking various biological samples, asking you to fill out a questionnaire, and we're really very, very optimistic that this program will result in a test that will clarify when a BRCA-positive woman is going to get her cancer and allow her to time the surgery. It'll also hopefully enable us to come up with some reliable forms of chemoprevention. This is all for the next 5, 10, 15 years. But it's incredibly important we get these samples. We've got women coming down from Scotland already. We're only in the Midlands here. I'm sure many of you can make it down to London. I look forward to seeing you in our clinic. Thank you very much.